CNVs can be some of the presenting findings. Just another chest X-ray which shows the finding of the bronchial atresia. So you can see this sort of perihilar opacity, which is of soft tissue density, and distal to that bronchial atresia, you see the overinflation that is involving the left upper zone. So if you see a hyperlucent lung with paucity of the vascular markings, that is the one that is abnormal, and the rest of it is the normal lung. So this is bronchial atresia. So case 15, does candidate 1 or 2 want to have another?
Yeah, I'm...
Can I go for it?
Yeah, candidate 2, please. Yeah, go ahead.
Yeah, this frontal radiograph, a pediatric group patient, is a frontal chest radiograph. So there is hyperinflation over the left lung, and with hyperlucency over the left lung as well. So I think the abnormality lies in the left lung. The right lung relatively appears clear. There's no nodules or consolidation. There is widening of the left intercostal space also. So there's an ill-defined cystic lucency over the left upper to mid zone. With a thin wall, with thin wall, and the pulmonary vasculature still can be seen superimposed at this region. So, okay. In conclusion, I would suspect my primary diagnosis would be left lung cystic lesion, CPEM, and also if there's previous infection, this could be a pneumatocyst. And it could be due to lung cavity as well. So I will review the previous radiograph and to get further history from the referring physician.
Okay, good, very good. The history is antenatal lung abnormality.
So if it's detected antenatally, so I would suspect this is a CPEM. So CT chest could be helpful to differentiate this with the hybrid lesion.
Perfect. So this is your CT chest.
Okay. Yeah. The selected images of the CT thorax in both mediastinal and lung window. This is a contrast study. I can see that there's cystic lesion at the left upper zone, and which I don't see any communication with the bronchial tree, and at these selected images, and I don't see any systemic supply, arterial or pulmonary drainage, or the venous drainage to this lesion. There is also a hypodense lesion over the mediastinal region, which is next to the cranial. Yeah, there's the lesion. So still, I will review the rest of the imaging to see whether there's connection to the bronchial tree, and if there is, I would suspect the cystic lesion could be a CPEM. And regarding the hypodense lesion at the mediastinal region, my differential diagnosis would be a soft tissue lesion. Most likely it's a lymph node. And review other images of the CT scan to see check the position of the mediastinal, whether it's in the middle hilar or it's at the posterior mediastinal region. So to give my further differential diagnosis. Yes.
Okay. No, that's well done. You didn't give up on one abnormality. That's really good. So this is actually in the middle mediastinum. You can see it clearly. It's in the subcarinal. So it's playing the bronchi, and it's actually a cystic lesion. I know it's not really well projected, but here you can see it's fluid attenuation. So this is actually a bronchogenic cyst. 85% of them are there in the mediastinum. 10 to 15% they can be within the lung, usually within the proximal third. And you have to differentiate them from enteric duplication cysts, which might be difficult, or pleuropericardial cysts. They can communicate with the tracheobronchial tree, so well done. It was not, and CT is the best to evaluate the relationship with the adjacent structures and look at the content of the cyst. They can be associated with congenital malformations, as in this case with CPAMs and others. And often bronchogenic cysts are asymptomatic and they're picked up incidentally, but they can sometimes cause compression on the surrounding structures or become infected and cause repeated pneumonias. So just to summarize, congenital thoracic malformations, they are usually diagnosed antenatally, like in most cases, especially if they are large and have a lot of cystic spaces. Fetal ultrasound is very good for initial diagnosis, and fetal MR is used to assess the lung volumes and to plan for intervention. Postnatally, the chest x-rays, as we saw, are not very sensitive or not very specific as well, and CT with contrast would be your gold standard to assess the lesion, the rest of the lung parenchyma, the vascular supply. And I would say try to establish that this is congenital thoracic malformation rather than try and get to exactly what it is, because you would always need to do a CT to exactly delineate everything. But you need to make sure that you don't miss a CDH, because that is an important condition and it's difficult to manage. Make sure you don't miss out on infections like we saw necrotizing pneumonias, and tumors like cystic tumors like pleuropulmonary blastomas or teratomas or neuroblastomas. So approach the lung structure systematically. Even on CT, you need to trace the tracheobronchial tree, trace the vascular supply, the fissural anatomy. Look for the internal characteristics. Are there cysts? What is the size of the cysts? Is there any mass effect or heterogeneity? And always keep your descriptions radiological and do not try to go into the pathology of it. Keep the clinical history in mind and try to make sure that you narrow your differentials to the most probable top 3 or like that. So there's a break, but I'm not sure if we can see all the cases after this. So let me just do a Q&A.
Yeah, we're meant to finish at 9, so I thought we'd just go to the questions.
Yeah.
So I will start reading them out. Give me 2 seconds. So back to case 7, which I think was a case with a pneumothorax. The question is, the person that was asking the question thought that they could see vascular markings on the chest x-ray laterally on the right side. Can you just put the x-ray back up, please?
Sorry, Toby, this CT doesn't move. Yeah, I mean, it was actually a supine film. So you have the key in that one was the deep sulcus sign, which was the main finding. So in supine films, you may not really see your the clear pleural line, but you would definitely be suspicious if you see a deep sulcus sign, which was really well identified by the candidate. So that was the main thing while I wait for the CT2.
Okay.
So,
we'll come back to case 7 because there's another question asking to show the deep sulcus sign, but we'll wait for the CT to behave itself. And then on case, oh wait, that's another one where you have to show. There's a question about do you know why group B streptococcal pneumonia patients are more prone to getting diaphragmatic hernias?
Yeah, they cause necrotizing pneumonias. So they are necrotizing and cavitating, and I think that's the reason why they're aggressive.
Yeah. Okay.
But not otherwise, not anything particularly that leads to CDH.
It's just that they will affect the diaphragm because of all the inflammatory stuff.
Yeah, and it would be a late, it's more in late older age children rather than.
than the congenital diaphragmatic
Yeah,
hernias.
than the congenital ones. Yeah.
Okay, perfect. Okay, and then the next question is, this is just a clarification. Does lung hyperplasia lead to increased or reduced lung density?
Lung hypoplasia.
Yeah.
So lung hypoplasia, it can have a normal density, honestly. If it is agenesis or if it is a collapsed lung, you would have high density, but just hypoplastic lung would probably appear normal density. I don't think it would appear as high or low. Obliterative bronchiolitis, on the other hand, might appear a bit more lucent.
Yeah, okay. I agree. I think the density is normally normal unless there's some superadded infection or some atelectasis. But I think the density is normally normal.
It's a smaller size, not
yeah,
just,
yeah, it's just a smaller volume of lung rather than anything else. Okay. Is it scrolling at all now? Because some questions are about specific cases. Okay. So
I've got
okay,
that.
perfect. So if we go to case 7, and if we just show the deep sulcus sign for the people in the audience, that'd be great.
Okay, it's gone all the way to the top now. Hang on.
Oh yeah, you were there. You were just there.
Case 7.
7, yeah. I think.
Yeah. So this is actually this was the 8 actually. You wanted the 7. Sorry.
Oh yeah, sorry, case 8. Sorry, I got my cases wrong. Yeah. No, it's case 8. I think the one with the deep sulcus.
Yeah, it's this one. Yeah. So yeah, this is actually the sign which was picked up really well by the candidate. So pneumothorax it's tough, and usually in supine films, especially when there are ventilation, there would be a supine portable film. You are not going to see the air rise up to the apex, and this is something that you have to be very, very like always look and make sure you don't miss this.
Okay, and then case 9, someone's asked about were there lucencies over the right shoulder. I don't remember seeing them, but
9.
On case 9, yeah, they've said there lucencies over the right shoulder, but I think that might just be soft tissue composite shadowing.
Yeah. Oh, you mean probably the next one, this one.
Oh yeah, that one. Yeah, maybe. Oh yeah, there, just in the above the clavicle.
I think it's something that is superimposed because there's a whole big. I think it's something external. It's not. It doesn't seem to be within the patient.
Yeah, it looks like it's external artifact.
Yeah.
Okay, and then they said, could you please mark the pneumothorax in the second on that case? Can you just show where the pneumothorax is, please?
Yeah, sorry. I actually. Can you just see this lucency here, and then there's a line between the rib?
We can't see your pointer. It's gone.
Oh, okay. Can you see it zoomed? I zoomed it a bit.
Yeah, we zoomed. Yeah, we can see it zoomed. Yeah.
So here, if you just see when I go back to my pointer, but if you can see along this rib intercostal region, and now if I zoom it, you can see this sort of line, which is along the thing, along the thorax.
Yeah.
So that is where the air pneumothorax has happened, and then it's tracking through the hernia along into the peritoneal cavity. So that's the diaphragmatic hernia with pneumothorax.
Okay, perfect. Thank you very much. And then, sorry, let me go back to my questions. The next question is on case 12. Why were the lung lobes atelectatic on the right side along with the area of overinflation?
Case 9.
Why was there areas? No, 12. Why were there areas of atelectasis with the overinflation?
So usually these children, they have CT scans under GA sometimes, and when they have ET tubes in and they're under GA and sedation, they would have these atelectasis, dependent atelectasis. So, and this child also had the background of absent pulmonary valve syndrome, so they have had other they would have had interventions, and that also would lead to atelectasis.
Oh yeah, so, okay. So it's a bit of chronic and a bit related to the general anaesthetic. Perfect.
Yeah.
And then how to differentiate hypodensity in lung as to whether it's from necrosis or trapped secretions in a pneumonia. It's a question. I feel like they look very different. So to differentiate hypodensity in the lung is or because of trapped secretions in a pneumonia. But I think secretions are normally hyperdense rather than hypodense.
Yeah. If it's in a bronchus, you mean in a bronchosale?
Yeah.
They would, and bronchus is, if the secretions are within a bronchus, it would be branching. So you would see them like fluid filled branching within the lungs. But if the lung is not enhancing, like in this case, you would see it as a more like a blob or non-enhancing along the lung margins. And in chronic cases of bronchial mucus secretions, you would get them as hyperdense, as in case of AGPAs or.
Okay. And do you have any specific windows you use to look to assess for necrosis or hypoenhancement of the lung parenchyma?
So if you just look at the mediastinal or soft tissue window, for example, here, you can see the lung enhancement here, but you cannot see it enhancing here anteriorly along the right lower lobe. So the normal collapsed lung would enhance, as in here, but the abnormal areas which are getting necrosed would not.
Okay. I think when you zoom in, we lose your pointer. So do you mind zooming out a little bit, and then we can see your pointer to see the different areas?
So here is the normal enhancing. You can, if you correlate it with the sort of a tongue shape, and you can see this enhancement. But here is the anterior bit. So if I zoom it now, the anterior bit doesn't enhance as well as you would see in a normal lung collapse.
Thank you very much. And then couple more questions. How can we differentiate congenital lobar emphysema from bronchial atresia?
That is a very difficult differential. I really admit to that. And you really need a CT stack to make sure. For example, this was the case of bronchial atresia, and I apologize for the painful, slow scrolling of the scan. But so in bronchial atresia, you would have usually the segmental or subsegmental bronchus is affected. And when you see, so the area that becomes hyperinflated is distal to that atretic bronchus. In congenital lobar emphysema, it would be affecting a whole lobe. So, for example, here it's the whole of the right middle lobe, and you don't really have that blind ending sort of bronchus, which is distal to which you would see it. So I think that is the main differentiating factor that I see. And other thing is the location. So this would be in the right middle lobe and right up and lower left upper lobe. Well, that would be a segmental sort of affection, not a whole lobe.
Yeah. Not as a whole lobe. Okay, thank you. So those are most of the questions. There are a couple, but I think you've answered them as you did the talk, so I've kind of skipped those. Are there any of the cardiac cases that you think are worth just showing without doing it Viva style? Any out of the ones that are left? Any good examples? Because we've got about 10 minutes.
I'll just briefly show some of the other chest cases rather than, because the cardiac would take a while.
Okay, fine. Yeah. So if there's any other cases,
yeah,
that'd be good.
I'll try and get past this CT again. I am really, really sorry about this. But main points which I wanted to say was in asymmetric lung densities, the area of lucency with paucity of pulmonary vascular markings, for example, here, as we just saw, that would be the area which is the abnormal one. So even on the X-ray, you have to look for the hyperlucency with paucity of lung markings. That is the abnormal one. So this is just a case of, again, I would let the CT scroll by and show you the static images. But you can see there's bronchiectasis bilaterally and the bronchial wall thickening. And in a child, when you see bilateral bronchiectasis, the most common differentials you should have is cystic fibrosis. And so this is just another patient who has cystic fibrosis. So you would see radiating bronchial wall thickening from the hila towards the periphery. And These patients would have a central line-in because they are usually treated with long-term antibiotic treatment. This is when they present with acute exacerbations. You can see there's bronchiectasis, tubular markings. You can see them as a linear or rounded lucencies with wall thickening. So cystic fibrosis is a common condition which has bilateral bronchiectasis in children. And it affects the middle and the upper lobes predominantly. You would have the tubular markings and then finger in glove sign. So always think about it. And if you see a multisystemic, this is a multisystemic disorder, so you would have to look at involvement of other organs like pancreas. In liver, it can cause biliary cirrhosis, fibrosis. Look at paranasal sinuses for mucosal thickening. So on CT, you would have bronchiectasis, and the differentials for cystic fibrosis or bronchiectasis, you can have bronchiectasis with primary immunodeficiency, or you can see them in obliterative bronchiolitis or in post-infection, especially after infections like TB. So, and cystic fibrosis, usually they would have screening at birth if the family history is positive. So they would get sweat chloride test and other lab markers to make sure when they are, if they have a positive family history. So that is cystic fibrosis. This is a case of, you can see this focal opacity in the right upper zone here, and this is a case of round pneumonia. So in young children, especially less than 8 years age, you can have round pneumonias because the collateral ventilation is not really well developed, and the exudates would then accumulate in that in those alveoli, and they cannot use the collateral ventilation pathways to diffuse and form like a lobar pneumonia, so as they would in an adult. So that's why they form a sort of a rounded sort of a shape, and be careful about them because they can be misread as a focal mass, and it sometimes there's a mass and you can think this is a round pneumonia. So if there's any clinical discrepancy, it doesn't, if clinically they are not suspecting infection, it might be worthwhile getting a follow-up X-ray just to look for resolution. And Streptococcus pneumonia cause more than 90% of these round pneumonias. You can also have bilateral multiple nodular opacities in children as well, and again metastasis is a differential. So in children, there's a very good differential in Chapman if you just want to have a look, but if the nodules are more than 5 millimeters in size and you're thinking neoplastic in children, the common differentials would be Wilms, Ewing's, neuroblastoma and osteosarcoma, and again Mets would be more common in the lower lobe and peripheral. You can have infections like staph, abscesses, septic emboli, or fungal infection in immunocompromised patients. So always ask about the history in these cases. Then I just have a couple of pneumomediastinum cases. You can see the continuous diaphragm sign and air along the aorta. Just briefly, this is a case who was on ventilation, had COVID pneumonia, and developed severe pneumomediastinum, pneumothoraces, as well as pneumoperitoneum. So that is just showing all the findings. Case 20. This is a really interesting case, but the key finding is this. So you have a right-sided aortic arch. Although the patient is rotated, you can see that this is more prominent. And in this case, this is an older child, so you would not really think of a thymus. A thymus would be this big only up to the age of maybe 5. But in an older child, if you can't see aortic knuckle on the left and on the right, you have to suspect the right aortic arch. This child had dysphagia, so they had a barium swallow, and you can see that there is narrowing in the upper esophagus here with posterior indentation. So you're thinking about external compression, and that could be a vascular ring. So if you have a right aortic arch and aberrant left subclavian, that is an obstructing anomaly. The other differential would be a double aortic arch, which would also be obstructing abnormality and can cause dysphagia or tracheal narrowing. So this is just the CT of that patient, and you can see there's a right arch. So when the aorta is to the right of the trachea, it is a right arch. If it is to the left, it's a normal left arch. And you can see the aberrant left subclavian there. And this is a case of the double aortic arch. where it is going on both sides, and you can see the 4 vessel sign because both the carotids and the subclavians would arise together from the respective arches. So just a brief on vascular ring and sling. So ring would be complete encircling of the trachea and esophagus, while a sling is when an anomalous LPA arises from the RPA. And if there is a stridor, you should always think of double aortic arch or an obstructing ring, and pulmonary. If there is no right aortic arch, then you have to consider a sling. And just to show the sling, it is like aberrant left pulmonary artery arising from the from the right pulmonary artery, and it would go behind the trachea, and this will go between the trachea and the esophagus. So this sling is the only vascular aberrant vessel that will go anterior to the trachea. All the others would be anterior to the esophagus. All the others would be posterior to the esophagus on a swallow. So a sling is the only abnormal one which will go anterior to the esophagus. And this is a case of H-shaped tracheoesophageal fistula. So you can see that on swallow, positive oral contrast, you can see that there is opacification of the trachea as well as the esophagus. And you can see this very slender sort of a tracking of the contrast anteriorly. So this is a H-type of tracheoesophageal fistula. And normal esophageal tubogram we do for detecting these H-type tracheoesophageal fistulas, and the contrast should the esophagus and not come anteriorly. Esophageal fistula. So this is just a case of the distal of the esophageal atresia with the distal fistula, because you can see gas in the distal thing, and you can see the tube coiling in the upper esophagus, which is distended. So slide about the recurrent chest infections and persistent pneumonia. Whenever you have persistent pneumonia or recurrent infections, think about infection with a pre-existing lung abnormality like we saw before. Think about bronchial obstruction with chronic inhaled foreign body or mucoid impaction, aspiration with reflux or H-type fistulas, which is rare but very important. I think I'll end there because I have a few more cases, but
Divya, Dr. Khan has suggested we can extend the time a little bit if you want to go through your last few cases.
How much time will you require?
I mean, it's pretty extensive, but I guess this is good enough. I guess I've shown them a summary of congenital thoracic and some cases about infections as well. So
what I mean is that this chance they will not get again. And
okay.
If we can easily extend it till 9:30. Those people who
I can show the next one as if any candidate wants to go ahead. It's a very good case, which is FRC.
Can I present this case?
Yeah, sure.
Yeah,
Please.
I've been provided with a frontal chest radiograph of skeletally immature patient who's showing evidence of the most prominent abnormality being a complete opacification of the right hemithorax, and there is evidence of a dense curvilinear opacity extending from the abdomen into the right hemithorax. I could not see the right hemidiaphragm separately. And there is mediastinal shift to the mediastinal tracheal contralateral shift to the left side, and there is no evidence of any pneumothorax. The aerated left lung appears normal, no pleural effusion on the left side. There is a bowel loop that is projecting over the mediastinum in the midline, And apart from this, the bones appear unremarkable, no focal lesions, no fractures. So summarizing my findings, right opaque hemithorax with a curvilinear density extending from the abdomen into the thorax, and a bowel loop that is projecting over the mediastinum. So my principal diagnosis will be congenital veino-lobar syndrome with scimitar sign, and that's also. I will inform my findings to the referring clinician and I'll inform the pediatric consultant in my routine practice, and would like to do a cross-sectional imaging to confirm my findings.
Okay, that was good. But so did you say this was calcification, or did you say this was?
I think it looks more like a dense curvilinear structure.
Okay, but do you think it could be a vessel when there's a whole white out of the and what do you think about the mass effect, because there is a mediastinal shift to the left?
Then there can be a concomitant pleural effusion also, or there can be a mass in the thorax also.
Yeah, correct. So this is actually suspicious for a mass, because you can see that there is calcification,
Okay.
which is abnormal.
Then if
And
it
you
is a
have a-
calcification, I think of a mass then.
Yeah, and you would want to go with cross-sectional, which is absolutely right. And so this patient had a CT, and okay, hang on.
So I've been provided with a coronal and axial reformatted and axial images of contrast CT chest showing evidence of a heterogeneously enhancing lesion with calcifications and fat densities within in the right and occupying the entire right hemithorax, causing contralateral mediastinal shift. And so may I know the age of the patient?
So it's a toddler, maybe 2 years old.
2 years old. Okay. So I'm thinking of terms because of the calcification. I'm thinking of in terms of a neuroblastoma, but with the fat and everything, I think teratoma also will be a good differential diagnosis. The third to round up the diagnosis might be any soft tissue sarcoma. I would like to inform the findings and do a biopsy to confirm the same.
Perfect. So I would put teratomas first, because whenever you see calcification and fat, always it's a germ cell tumor. And this patient had a teratoma, and usually they are seen as anterior mediastinal masses, and they account for approximately 25% of anterior mediastinal masses in children. In children less than 1 year age, immature ones are more common, and they may be detected antenatally, and almost 80% would occur in the anterior mediastinum, and they always contain fat and calcification, which is the diagnostic. That is what the money is. And they can rupture, they can cause mass effect, and they sometimes can have producing hormones like HCG or TSH. So the differential diagnosis would be other germ cell tumors, thymolipoma, but that is again not common in kids. And if it is large like this, it can also be an undifferentiated sarcoma, like you said, which can look similar and like a liposarcoma or any sarcoma. And the diagnosis then would be established by histopathology only. The other thing was that always do a contrast enhanced CT in these cases, because you want to see the relationship with the vessels, because if they want to go in and excise this, they want to make sure how it is related to the heart and to the large vessels. So make sure that you always do this with contrast as well. So next case.
So I've been provided with a frontal radiograph of a skeletally immature patient. The most striking abnormality being there is opacification in the right paramediastinal region, and there is blunting of the right costophrenic angle. I couldn't see the right heart border separately from the lesion, and apart from this, the left, I could make out the left hemidiaphragm, and there is increased cardiac silhouette suggestive of a cardiomegaly.
Okay.
Yeah.
So where do you think this? Where do you think it lies?
Yeah, I think it is in the anterior mediastinum because it's showing loss of cardiac silhouette with the right cardiac border. There is no evidence of any scalloping or erosion of the ribs.
Correct. And you can see a hilum overlay sign as well. You can see the hilum through the thing as well. So really well described. And what would you do next?
Yeah, I would inform the findings to the referring clinician, and in my routine practice, inform my pediatric colleague and do a cross-sectional imaging, likely contrast and CT for further evaluation.
Yeah, well done. And this is your CT.
Okay. These are the contrast and CT images of the same patient, showing evidence of a homogeneously enhancing lesion, which is showing loss of fat planes with the vessels, great vessels of the thorax, and it is a conglomerate. Looks like a conglomerated lymph nodal mass in the female patient. And there is also evidence of a pleural effusion on the right side, and also evidence of a pericardial effusion. It's a large conglomerate mass. So and there is also hepatosplenomegaly. So keeping in with these features of interpretation, likely to be a lymphoma, which in this patient. So I'll inform the findings to the referring clinician, inform a pediatric colleague, do oncology MDT, and do a biopsy for immunohistochemistry for further treatment and management, and compare with previous image.
Excellent. That's wonderful. This child actually has a new ALL diagnosis. So remember, in kids, leukemia also is an important differential for such mediastinal soft tissue abnormalities.
I have a small doubt. Is there a hydropneumothorax on the right side? I think lung window has not been provided, but
on this side, yeah, they had they've had a chest drain put in, so they would have after that effusion.
Okay.
So that is just interventional. But they had new ALL diagnosis with a white cell count of more than 100. So it is in the spectrum of lymphoproliferative disorders, and leukemia is an important differential. And this is another case.
So I've been provided with a AP erect radiograph of a skeletally immature patient. The main positive finding being here a complete opacification of the left hemithorax with the lucency in the left upper zone, causing contralateral mediastinal and tracheal shift. Could not make out the left hemidiaphragm. The right CP angle is obscured. Left CP angle, costophrenic angle is obscured. The visualized bones. I couldn't make out. Yeah, the visualized bones appear unremarkable. No focal lesions. So based on this, these findings of left opaque hemithorax with contralateral shift and lucency, my differentials will be a gross pleural effusion or a mass with concomitant pleural effusion causing contralateral mediastinal shift. So I inform my findings to the referring clinician, inform my pediatric colleague, and do an ultrasound chest. And if it doesn't if it doesn't solve the problem, go for cross-sectional imaging. I would like to compare with previous imaging also.
Okay, that's really good. I'm so happy you said ultrasound and that you listened to the first half of the session really well. So this is your ultrasound image, and then you also have a follow-up chest X-ray of the same patient after they have put a drain in.
Okay. I think the ultrasound image, the curvilinear probe showing massive pleural effusion on the left side. There is a hyperechoic. I don't know whether it's a collapsed lung or there is a mass there. Yeah.
Okay, and the radiograph after they have put a drain here on the left.
Okay, I think there is some increased aeration of the left upper and mid zones compared to previously, and there is the decrease in the mediastinal shift. I think there is the effusion still persisting, but it has decreased compared to previously.
Can you see an outline of a mediastinal based opacity here?
Yeah. I think there is enlarged mediastinal shadow, which is going above the level of the heart. I think it is showing loss of silhouette with the cardia. So I think the lesion is in the anterior mediastinum because of the loss of silhouette with the heart.
So this is a 15-year-old, and she presented with acute breathlessness and left pleural effusion. And again, this is the CT that we did after.
the coronal contrast enhanced reformatted images showing evidence of a conglomerate mass in the prevascular and visual compartments of the mediastinum with loss of fat planes with the vessels and the heart, and there is a pericardial effusion. Apart from this, there is evidence of a hypo-enhancing lesions within the kidney and large lymph nodes in mesenteric and pelvic lymph nodes, keeping in with either lymphoma or leukemia, mostly lymphomoid, above and below the diaphragm.
Okay.
And inform the findings to the referring clinician and inform the pediatric colleague and do a biopsy for further evaluation.
Okay. They also have filling defects here. I'll just zoom it for you. In the pulmonary emboli, and you can see filling defects inside the renal vessels as well. I think the images are too small to actually justify that, but definitely they have lesions which are hypotenuating and involving both the kidneys, and there are pelvic lymph nodes and also like a conglomerated confluent lymph nodal mass in the mesentery.
Yeah.
And in the anteromediastinum, they also have a pericardial effusion. So this patient also has a blastic phase of the lymphoma, and so basically lymphoma leukemia, you have to be aware that they are in the spectrum of what I called is SALTI. They are like the lesions which you have to keep in mind can appear as anything. So in SALTI, I consider sarcoidosis, amyloidosis, lymphoma leukemia, tuberculosis, and inflammatory IgG4 disease. So these five, that acronym of SALTI, you have to be very careful. And on CT, these lymphoma leukemias, they would appear as soft tissue attenuation masses. They are smooth, lobulated margin. They'll conform to the surrounding structures. So they won't really invade through, and but they would encase and they would compress the vessels. That is called the sandwich sign. They would not really obstruct them completely like aggressive tumor, but they would just go around them and sort of form around them. And you would see a pleural effusion in 50% of the cases, which is usually unilateral, as you saw, and that was a pleural deposit within the ultrasound. So ultrasound really helps to see whether there is some involvement of the pleura, thickening or nodular appearance. They also have pericardial effusion commonly, as you saw in both the cases, and less commonly they can invade the lung parenchyma and have chest wall invasion. But calcification is not common in lymphoma leukemia unless they have had therapy, and then it's post treatment related calcifications. And usually these patients, they appear dramatically, but when they are given treatment, these lymphomatous lesions, they would just melt away with near complete resolution. Always think about doing PET CT because that is the imaging of choice for complete lymphoma staging and to assess the response to treatment. They have a Duoville score, which is usually used to see response. And the differential diagnosis would be thymomas, especially when the thymus is involved, and thymic rebound or hyperplasia post-treatment. Sometimes if they are post-treatment for other cancers as well, it might be tricky to differentiate the thymic rebound from a lesion. And just a brief thing about middle mediastinal masses, although we didn't see anything, but you would see the widened paratracheal stripes, and you would see the displaced recess, and you wouldn't see it's like the opposite of what you saw in the anterior mediastinal. So in approach to mediastinal masses, the chest X-ray is important, but always do the CT with contrast for further assessment. MRI is important for the posterior mediastinal masses, especially to assess for the intraspinal extension. And in children, you would commonly see neuroblastomas. So that is important that you look at intraspinal extension in neuroblastomas. So just a brief summary on the anterior, middle, and posterior mediastinal masses. The anterior one, the 4Ts, which is the thymus, thymic rebound, lymphadenopathy, teratoma, thymic infiltration, which can be in leukemia, lymphoma as well, thymoma, thymic cyst. Morgagni hernias are an important anterior mediastinal mass as well, and vascular malformations. Middle mediastinum, you can have lymphadenopathy, as we just saw. You can have bronchopulmonary foregut malformation. We saw the bronchogenic cyst, which was in the middle mediastinum and splaying the carina. You can have congenital vascular rings or aortic dilatation, which would also be in the middle mediastinum, and hiatus hernias. And posteriorly, you would have the neurogenic tumors. So anything neuro would be posterior: neuroblastoma, ganglioneuroblastoma, ganglioneuroma. Spinal abscesses, which can be caused by staphylococcus or TB. Bronchopulmonary foregut malformation, neuroenteric cyst, that would also appear as posterior mediastinal and usually associated with vertebral defects. Spinal tumors like P-net and Ewing's tumors from the vertebra would be posterior mediastinal. Bocta-like hernia is also usually seen posteriorly. And obviously trauma, you can have pre-paravertebral hematomas. So this was the end of the second session.